Hi everybody, Neil Kravitz here. I hope you're enjoying these daily clinical pearls. I received a nice email question from an orthodontist who is enjoying these pearls, which makes me so happy. So if you do have questions and you want me to review a pearl, just email me and I will create a video on it. And his question was how I address midlines at the end of treatment. So there's a lot to unpack here. I'll speak a little bit fast, and we can always go back to this topic and expand it more. So first and foremost, you need to make sure your midlines match the facial midline. You also need to make sure you are aware when the midlines do not match, is this a problem with the maxillary arch or the mandibular arch? So for example, ideally we want the maxillary midline to match the facial midline. The facial midline is going to be between the eyes. Patients often focus on nasal tip and philtrum, but those can deviate asymmetrically. So I do have a patient where I am moving the maxillary midline a little bit away from the facial midline, but in a way that masks the nasal tip and philtrum, which are both deviating a little bit to the left. So you can find a compromise somewhere between. But what if you have a patient whose mandibular dental midline matches the facial midline, but the maxillary midline is way off to the side? Maybe you're taking out a premolar on one side, for example, to swing the maxillary dental midline. A lot of times you have midlines that approximate the facial midline but don't quite match up to each other. The maxillary and mandibular dental midline don't quite match up to each other, and that's often due to a bolt-in discrepancy. It's very simple with midlines, right? If the canines are socked in class 1 occlusion and you don't have a bolt-in discrepancy, your midlines should match up. If your canines are socked in class 1 and spaces are fully consolidated and your midlines don't match, you do have a bolt-in discrepancy. So you can do IPR, you can do lower IPR. You also can simply just open space distal to the maxillary lateral incisors, which are often the culprit for midlines that do not match. So I have no problem opening space distal to an upper 2 and adding a little bit of composite as a kind of retainer, a restorative retainer. Henry Fields talked about this almost 50 years ago, where you add a little bit of composite to hold the space in preparation for maybe a dentist doing it better when the patient's a little bit older. So to review, there's a lot of information here. You have to get the midlines earlier in treatment, and if the mandibular midline matches the facial midline and you have a maxillary midline deviation, maybe you're just taking out a single premolar on one side. That's always an option. Maybe you're doing asymmetrical extractions if multiple teeth need to be extracted for crowding. All of those are very good, but you want to get the dental midlines coinciding with your agreed upon facial midline pretty early. Once you have canines socked in, if your dental midlines do not coincide with each other, think bolt-in and be okay with IPR in the lower arch and space opening in the upper arch. For me, I prefer to open up space distal to the upper 2s. And I think that works very well, and I have no problem doing a little bit of complementary composite bonding to hold that space until the patient can see a dentist when they're older. I hope you enjoyed this pearl. Let me know what you do to make sure your dental midlines coincide. I'll see you guys next week for another clinical pearl. Bye.